the optic nerve, the second cranial nerve. Like the olfactory nerve, this is also a sensory nerve. The optic nerve starts from the retina of the eye and then exits through the optic canal of the sphenoid bone. The nerves from both eyes converge anterior to the pituitary to form the optic chiasma. Here, the fibers from the nasal or medial half of each retina cross over to the optic tracts of the opposite side. The fibers from the temporal half of each retina remain ipsilateral. The nerves synapse at the lateral geniculate bodies in the thalamus, from which the optic radiations emerge and terminate at the visual cortex of the occipital lobes. Begin the examination of the optic nerve with a general observation of the external features of the eyes, the eyelids, the conjunctiva, and the whole orbit in general. Is there any evidence of exophthalmos or the reverse, enophthalmos? First, assess the pupil size and symmetry. When performing papillary light reaction, remember that the afferent component is the optic nerve, and papillary constriction is by the parasympathetic component of the third cranial nerve. Check for consensual light reflex, which is pupil constriction in the eye which is not being tested. If both pupils are large or small, consider if the patient is taking mydriatic or miotic drugs. Senile miosis or small pupils is often observed in the elderly. A small irregular pupil that does not respond to light, but with normal accommodation, may indicate Argyll-Robertson's pupil. Causes include syphilis, diabetes, and rarely midbrain lesions and multiple sclerosis. A pupil which does not react to light and accommodation is slow indicates Holmes AD pupil, a degeneration of the ciliary ganglion. Now test for visual acuity. Place a Snellen chart 6 meters away from the patient. Test each eye separately to see if the patient is able to read the chart. Can I get you to block the other eye and again try and read the smallest print?
LHTOCNEA.
Fine, thank you. Normal eyesight is termed 6/6 vision, or in empirical measures 20/20 vision. This means that at 6 meters away, the patient is able to read what a normal person should be able to read at that distance. Alternatively, if for example you have 6/12 vision, it means that when you stand 6 meters away from the chart, you can see what a normal person would be able to see standing 12 meters away from the chart. Poor vision is usually caused by refractive errors by which the patient should be able to compensate with corrective spectacles. Ask the patient to read the smallest print and record your findings, both with and without spectacles. To confirm that poor visual acuity is due to a refractive error, you can ask the patient to look through a card with a pinhole to see if this improves focusing. And look at the smallest print and tell me if it appears different. Okay, how is it?
It's sharper.
It's sharper. Can you repeat the same with the other eye now? Block the other eye. And how is that?
It's much sharper as well.
Okay, thank you. Next, check for vision of the peripheral fields. Preferably use a wide-headed pin. Sit opposite the patient with a distance of about 2 feet from each other's face. Start by covering the patient's right eye and your own left eye. Test the visual field of the patient's left eye. Both the examiner's eye and the patient's eye should be fixed on the bridge of each other's nose. Bring in the pin from each quadrant until it comes into view for both parties. This is of course a crude test, and it assumes that the examiner's peripheral vision is normal. Remember to take into consideration and to map out the blind spot. This is essentially the optic disc, which is devoid of rods and cones. Whilst continuing to fixate the eyes, slowly move your object from laterally to medially. Tell the patient to indicate when the object first disappears from view and again when it reappears. So block that eye first. Okay. Now when the red pin disappears, let me know.
No. And it's back.
It's back now, yeah? Again, tell me when it disappears.
And it's gone. And it's back.
Now can you block the other eye? And again, let's do the same. Tell me when it disappears and again when it reappears.
It's disappeared. And it's back.
And again.
It's gone. And it's back.
Defects in the visual fields must be defined according to their distribution. If a defect is found near the center of the visual fields, this is termed as central scotoma, and the test should be repeated using a red-headed pin. Lesions involving the optic nerve include optic neuritis, as in multiple sclerosis, pituitary tumors, and infarcts from the posterior cerebral artery. Note that pituitary enlargement, when advanced, often leads to bitemporal hemianopia or tunnel vision. In homonymous hemianopias, which are incongruous, it indicates lesions of the optic tract, and if congruous, the lesion is after the lateral geniculate body. If the macula is spared, it indicates lesions of the occipital lobes. Next, examine the fundi of the eyes using an ophthalmoscope. Become familiar with the instrument and know how to use it effectively. For ophthalmoscopy, you need to have the room light dimmed. First, check for the red reflex. Then look for corneal lesions and opacities such as cataracts or floaters. From about a foot away, shine the light through the eye and observe the red-pink appearance of the pupil. Next, examine the fundi of the eyes. Refer to the use of equipment menu for a full description on how to use the diagnostic kit. Set the ophthalmoscope to +10 diopters to examine the anterior portion of the eye, gradually reduce it to 0 or until the retina comes into focus. Next, examine the different structures of the retina, the optic disc, the vessels, and the macula. Aim your beam towards the center of the back of the patient's head, or about 15 degrees from the line of fixation. The optic disc is located by finding the place where the retinal vessels converge. Assess its borders and color. When examining the optic disc, look for signs of papilledema, glaucoma, and demyelinating diseases. The paler area of the optic cup is located within the optic disc towards the nasal side. If enlarged, consider the possibility of glaucoma. In papilledema, the disc is swollen and the margins are blurred. The cup may not be distinguishable, and it often indicates increased intracranial pressure. Then locate the macula. This is the area of central vision, and it is found lateral to the optic disc. This area should be clear of vessels. The retinal arteries are lighter in color than the veins. Check for tortuous vessels and the appearance of silver wiring, which is produced by distended arteries as they reflect the light. Note any arteriovenous nipping. This is caused by high pressure artery partially occluding a vein passing underneath it. Examine the retina for hemorrhages, pigmentation, and exudates, signs of hypertensive retinopathy. Also consider atherosclerotic changes to the vessels. In diabetic retinopathy, there will be hemorrhages, cotton wool spots, new vessel formation, dots and blots, exudates, and vitreous hemorrhages.